So I wanted to go over I had a client that I was unsuccessful with, and I'm not sure if like my thought process as far as my programming was wrong, or if I just didn't coach her properly. And I kind of want to get an idea of what you would have done in this situation, because it's a little bit out of my comfort zone as far as like types of people that I work with. So,
let's talk about it.
So she's a client. She's super hypermobile, right shoulder pain, and a frozen left shoulder in the past. So I assessed her. She's narrow ISA, like hips were super loosey-goosey, except for when I did knee to chest, the straight leg would start to come up pretty soon.
Okay.
So no extension. Then her shoulders, she had like, on her left side, she had 1 or 2 degrees of ER, like none. I've never seen anyone with that little. And on the right side, it wasn't much better. And then IR was pretty limited as well.
On the right side or the left side?
Both.
Okay.
Both sides.
Yep.
Yeah. I'd say the left side was a little bit stiffer in general, but the right side is where the pain was. So, so my thought process was like, so I taught her the basics of like tucking, how to breathe, how to inhale while keeping the tension, all that type of stuff. So my thought process was like, I need to invert her to get that ISA dynamic, right? And then I was thinking I need to open up the ERs first, because again, she's narrow with like A to P compressed, right? So I did we just did basic like 90-90 breathing, no changes. I did the one where she kind of like inverts, so she rolls her hips all the way up. So it's like, yeah.
Oh, like a bridge. So you bridged her all the way up.
Kind of, yeah. And no changes at all. So then I took her to the wall. We did like a wall squat hold, right? A little bit of change. And then I did a heels elevated squat where I had her drop down just a little bit and just do her breaths from there. And on the left side, like it went to like 45 degrees, I'd say, of
Nice.
PR, pretty quick. Yeah. The right side, every time I would look at her shoulder, it would like kind of flare her up a little bit. So I wasn't really too keen on like moving things around on that right side. But so I thought to myself, okay, great. I'm going to have her do the 2 moves, the inverted breaths and the squat hold. And we'll just keep doing that for a little while and see where we go. So I came back a few days later, and the ER was just as terrible as it was on the first day. And she said like she now has like a little bit of discomfort in both shoulders. So I thought, okay, well, let's try it again and see what happens. Maybe she wasn't executing properly. And we did. Same thing with the ER on the left side. It went back to like, 50, 45 degrees or something like that. And the same story again when I came back. It's like, and then both shoulders were kind of hurting and they were stiff again. So I wasn't sure exactly what was going on. So I was like, okay, let me throw some, so I gave her like the supine cross connect. Not much changes. Didn't really do much for her. So she didn't really do it very often. So, and then I gave her just like, I was like, all right, well, I'm going to throw some sort of pump handle expansion at her and just see what happens. Right. So I put her on her back in a 90-90 and just had her do like a right arm reach like that. And that seemed to help her. Like she said it would, because every time she would put on her deodorant, she said it would really bug her shoulder. But after she did that, it was like, it felt a little bit better. So she could feel a little bit of improvement there, but still shoulder pain. Right. And then we kind of just, from there, I didn't really know where to go. I feel like I couldn't really make any progress in any direction. So I'm just curious, like, what would you have done in that situation? And do you think it was a programming issue, or do you think she just wasn't executing properly? Maybe I didn't coach her properly. I don't know.
Well, this is good. So let's walk through each of the individual steps of the stack, because I think there's probably a few areas that I think you'll recognize where you could go with this person. So I want you to just look at the lower body position selections you chose, which ones worked versus which ones didn't. So you had 90-90 or Lewitt, and then you had wall squat, and then you had a decline. So why don't you contrast the differences of the pelvic positions in each of those?
Right. So 90-90 and 90-90 is she's in IR at the hips.
Yep.
Right. Whereas the wall squat, she's an ER. So.
And what does she need first?
She needs ER first.
Yeah.
Although her ER, her knee to chest, like the hip flexion looked pretty good. I don't know, maybe I didn't measure it properly, but she got pretty high up there with the knee.
Okay. And how soon? So a couple things with the knee to chest, and then I'm going to ask you another test. So with the knee to chest, how soon did the down leg move? Or that's one thing to look at, and the other thing would be, how soon did you see movement in the ab wall? Because a lot of times what will happen is some people can get a good knee to chest, but you'll see this happen, and the way you'll see it is you'll see like a bend either in the ab wall, you might see some creases in the shirt, and I'll walk back and forth into that range just to make sure I'm not tricking myself into seeing what I want to see. But if you start seeing that, that means that they've lost relative motion at the pelvis and the sacrum, and they're just orienting the whole thing backwards to try to get all the way up.
Gotcha.
So that would be something to look at. The other thing would be, what was her straight leg raise?
I don't remember.
Okay. Sometimes if that's really limited, those would be telltale signs that they need more early-based ER activities.
When you say really limited, you mean like not even 45 degrees or
45 or less?
Okay, so that means that she's lost ER on that early ER. Okay.
Yeah.
It would be like between. So the tough thing with it is like, if you look at, there's a study by the great article by Don Newman, who wrote the kinesiology book. The transition point from which the posterior rotators go from more ER to IR is somewhere between 45 and 60. 45, it's like even, and then 60, it's definitely IR, or IRing is happening. So you figure if I got anything less than that, I'm probably in the ER ranges. So a lot of times if it's really limited early and you see knee to chest, kind of like those extraneous movements happen too. And then the third thing would be you have ER at 90 limited. You're thinking, I probably need more ER-based things.
Okay. Mm-hmm. Okay. So maybe I should have given her I don't know, like a hook line supine drill.
That could have been one possibility.
And then the wall squat was pretty good, I think. As far as I did see changes there. Yeah.
Yeah, and I'm wondering if that's at least one factor as to why you got changes. And I'm just going to kind of engineer this all the way up. So you need ER-based things at the bottom. So think high depth stuff or early phases of flexion stuff. Now, exhale. How would you say that was?
How was her exhale? Mm-hmm. Seemed fine. I don't know. It was weird because I would coach her. I'd be like, okay, 10 to 12 seconds out, right? Okay. Mm-hmm. And then she'd be sitting there, right? And then we get to 12 seconds, and then she could just keep going and keep going. So it took me a while to get her to make sure that she really got it all out and that like the abs are really kicking in. Mm-hmm. But it seemed okay.
Great.
It seemed okay.
Cool.
After some time. Yeah.
Yep. So that's good. Then let's just say we got that for the sake of argument. Now with the inhale, and this is going to be key for someone who's had a history of frozen shoulder if they're really restricted in the thorax. Was it the keys that I look for? Silent, in through the nose, mouth closed, and then the fourth thing would be minimal neck, chest engagement. Did you have that?
Wasn't really looking for all that. As much as I should have, I guess, yeah.
Yeah, that would be a thing I would strongly consider looking for. And the reason why that is you can get a really good exhale, and you can really, keep ab tension, so on and so forth. But if you're using all of your accessory muscles to lift the rib cage up as a unit, you're not going to get that expansion into the thorax. And narrow, female, compressed a lot up top, strong likelihood that could be an area that you might need to focus on a bit more.
Okay, and quick side note about that. because I've been having some issues with some of my clients and myself with this, is if they nail the exhale, they get all the air out and the abs really kick in and they do a good job of keeping those abs on, and they inhale, it's like they can only get enough air in to give me maybe a 2 or 3 second exhale on the next breath. So how do you coach people through that so that they can get like 5 breaths per set, you know?
Yeah, well, a couple things. One, you got to make sure that the exhale is, or the ab tension that you're creating is not overly superficial to where I'm folding over. That's one thing. Two, the other thing would be, it may be that they're that restricted in the upper thorax that they can only expand so far. And so if that's the case, it's like...
Is it okay to do like 1 breath and then rest your second, and then do 1 breath and rest your second? Okay.
As the great philosopher T.I. once said, you can breathe however you like. He didn't say that, but he could. He could.
He should have if he did.
He should have, yeah. When I make an album off of some of my favorite songs that I will interject things in, that's going to be one of them. Just don't forget it, yeah. 2021, folks, December. What you going to do about it? So I would so that would be one thing. The other thing would be if you notice someone's doing like the sniff to get it in, I'm talking about so that's them still trying to use neck to try to pull the air in, because they could be occluding the airway up top. So if there's someone who's double chinning it, well, when you're in this type of posture, the upper airway is significantly smaller, so you can't pull as much air in that respective area. So
like towel.
You could do a towel or cue them to just move their chin away from their neck slightly, almost the CPR position. Not like way tipped back, but that will help open up the airway, and sometimes that can make it a little bit easier to get air in.
Okay.
So check the neck, though, with back to your girl. Check the neck. Make sure that that's chilling. If it's not, generally what I do, and so maybe you do a wall squat with a right reach, because that seemed to help her right shoulder a little bit, and we'll talk into maybe why that is. With the left hand, have her put her hand on her neck.
How much shoulder flexion are you in on that right shoulder when you're reaching?
Depends on what you're trying to drive. If you were at like 70, 80 and you're driving IR, I think that could be beneficial for her for 2 reasons. But we'll dive into that in a second. Why? But hand on the neck, have her inhale, make sure this stays chilling like Bob Dylan.
Okay.
If it's not, say, hey, maybe just cultivate awareness just like you do with ab tension. Say, hey, can you go through and breathe without kicking that in? If she can't, then I would forget about the open mouth sigh exhale and just have mouth closed, nasal breathing easy. So you just make the entire move low tension, because you need to be able to create space for her to expand. And if there's tension in the body throughout everything, you're not going to create the space you need to get the movement changes.
Right. And how does a nasal exhale compare with, I know the pursed lip is external obliques, fogging up the mirrors, internal obliques. What's the nose? What are you going to get?
It's just being able to exhale with less overall tension in the body. So you're not going to get as much airflow, but if I also have less tension in the body, I can create more expansion because there's less resistance.
The really tight wides that love to kick things on, so start with that maybe? Okay.
Absolutely. I've been moving to that a lot. If I notice with the exhale, you get someone who's just wrecked us, damn near killed us for days. Yeah. Yep. We'll be part of the Tight Exhalers Anonymous group. And if you, despite your best efforts, they breathe in and neck is just kicking in with reckless abandon, I just go nasal breathing. And I've been doing a lot more, rolling and things like that, and just like basically like just chilling moves to try to get them to move with less tension. And nasal breathing is a way of doing that on the breathing side of things. It works pretty well.
Okay.
Yep. So that would be the inhale side of things. So we got ER with the pelvis. Make sure the breathing sequence is low tension. That's step 2. Step 3 is you're reaching. So let's look at the moves that seem to be most impactful. So a right arm reach was impactful. And then your
And I had her reaching like this too, like.
okay. So why would those be helpful?
I mean, why this as opposed to a straight arm, or why would the right arm reach be helpful?
Right arm reach, and then I'm sorry. What did you do with the other ones that were helpful? You did, with your wall squat. Did you do
squat? Yeah. So I had her kind of doubling like this.
Okay.
Reaching the elbows because I feel like I get more scapular movement there as opposed to like the straight arm.
Perfect. Yep. And that's also going to get you more expansion where?
Posterior lower.
Yeah. Yeah, especially if you're in that 0 to 60 range. And then the elbow flexion is going to drive ER of the humerus, especially if it's past 90.
Right.
Which is going to get you more posterior.
Gotcha. Yeah.
Which is good. She needs that. But then now think about this, and I think this is going to help you design a solid moves for her. What was the difference with the unilateral reach versus the bilateral?
You're getting rotation when you reach, so she's going to get more IR on that right side. And ER on the left side.
Yes, which, if we look at the measures that you told me, right? So she, on the left, I have A to P compression because I'm limited in ER and IR. On the right, I have a loss of IR, but I have ER. Right? So, from a rotational perspective, what is her resting bias?
The opposite. Where is she going? A little bit rotated to the right.
She's going to be more rotated to the right. So then what you did, so then think about this, right? If I'm more rotated to the right, which shoulder is going to have more loading through it? Just think about where the movement's available.
Right side.
Right side. So she can't offload that side.
Mm.
So when you reached right, that allowed her to turn to the left, allows her to offload.
Right.
So I would say your three keys would be you need to well, the overarching key is you need to get her to be able to rotate left. And the concepts that you would need would be high depth flexion, one. The second thing would be you need breathing sequence to be chill so you can create the turn. And then the third thing would be get her to turn left.
Okay. So a high depth squat with the right arm reach would be money in this case.
It could be, yes. Also, have you seen my upper body roll that I've been doing?
No.
Okay, look it up on YouTube, upper body roll. It is awful. It's probably the hardest thing I've had most people do. But if you have her just go to the left with that, because you essentially, it's kind of like segmental rolling, SFMA style, but I think it's a little bit more focused on relative motions. That could be money. So you might look into that. And then if that's too hard, I would just put a pillow underneath her rear so she's a little bit rotated to the left anyways. But I think if you do that, no one will mess with you.